So, our session dealt with looking at PAD in the context of long-term care settings. I would like to kind of summarize what I heard, but really from a much broader perspective of looking at PAD from a perspective of particularly vulnerable populations, in this case, frail elderly, geriatric population, and I want to extend that to medically underserved ethnic minority communities, because we also heard a lot about that. So I would say, just briefly, first of all, I personally have a kind of moral objection to the practice, I'll just put, of PAD, so I'm not an advocate. I also have concerns, and we haven't discussed this so much in the session, but I think it's a huge issue. I have concerns about the implications and the impact of wide-scale adaptation of this practice on the profession of medicine, particularly in the context of how medicine is practiced in the U.S. in this very fragmented, disorderly way it often is practiced. And for very vulnerable, medically underserved patients who have few relationships of long-term with providers or physicians, this is particularly, I think, problematic. That said, since assisted dying is a reality, I guess the question is, what should we think about in terms of addressing some research gaps in trying to understand the impact in particularly vulnerable population? I would say, first of all, that we've also heard a lot about differences in perspectives in a particular minority community, the African American community. We heard Dr. Silva weighed in. We've heard some others. There clearly, as has been presented by one of the speakers, a small body of literature and empirical data suggesting that there are some African American populations and communities who do not favor this. But there also are some pretty powerful anecdotes on the other side. For example, I was quite surprised, actually, that Archbishop Desmond Tutu in South Africa came out in favor of assisted suicide, actually reversing a lifelong kind of opinion against this. He was particularly, I think, influenced by what he saw as a prolonged, undignified death of Nelson Mandela. So the African American community, like any community, is not a monolith, is not homogeneous, and it just brings to fore that we need much better on-the-ground, ethnographic kind of data that really crosses not just racial, ethnic strata, but also socioeconomic strata within a racial and ethnic group. Because to me, and I think we heard this very loud and clear, and I'm sure Joanne will pick up more on this, is that the big concern, particularly with respect to vulnerable populations, is the threat to voluntariness of this procedure. Now, it's one thing to say, well, it's voluntary and the patient will take the medication and there are all these things in place, but I would actually ask us to consider two things. One, as the process is scaled up, how slippery does that slippery slope becomes in terms of ensuring that these protections around voluntariness remain. And secondly, I think we need to have a much more subtle and expansive view of the kinds of things that would pose threats to the integrity of the voluntariness concept. And I think these kinds of social determinants of health and living and dying are extremely critical, and I think that unless we are hearing from the people who are most directly affected, we really are flying very blind into how we understand the impact of these social factors in decisions about this and other health decisions. So I'll say that.
Thanks, Rich. I have only a little to add to Rich's summary. I think that those of us who, or at least sometimes, deal with this issue have to be aware of our social context. The new budget proposes to cut nearly $1 trillion out of Medicare and Medicaid. We have essentially no housing vouchers at this point. The Older Americans Act is budgeted at lower than its current rate. We really are in a period in which there will be a very large number of very poor and unsupported disabled people of all ages, but especially many of us in our own old age. So we are writing our future, and we can write it to pretend that this is all a matter of individual choice, and try really hard not to notice the degree to which we are social creatures and are responsive to cues and to stimuli in our environment. And if physician aid in death becomes very standard, that will be part of the environment. It won't matter whether a doctor brings it up or not. It'll just be part of what everybody knows is available. And it'll be part of people's role definition as to their view on it. So, when we did the support study, we discovered, much to my chagrin, that there was much less decision-making and much more people living up to what they perceived to be their role. I'm a father, I'm going to be home to take care of my kids. I'm a good person, I do this in the following ways. Well, those definitions of roles and good persons are very subject to the movies, the stories we tell, the things we're willing to share. And to the extent that we are willing to build this all on the experience of relatively well-off people with cancer who have access to many things, we will not be telling the stories of most people, but they will be swept in. So we have to, I think, be very worried about discrimination at a very subtle, broad community basis against aged people and against people with disabilities. We have to be very worried about the power relationships. I did a lot of work in care transitions. It is amazing to pull together the recipients of care, the home care agency, the hospice maybe, the nursing home, and the hospital. The hospital folks are so arrogant. And they have, it's a $10,000 thing as an error in a hospital. Get down to the patient, it's a $10 error that matters. And the difference in the power relationships are really stunning, and they are less in other countries. I think we have to realize that physician aid in death is at the present time something of an intriguing sideshow, because it brings together a whole lot of power and electricity and has lots and lots of very clever and interesting questions. It's really much harder to make something sensational out of somebody not getting supper. It's really hard to make a news story out of there being no housing vouchers. But that's what affects many, many more people. And it puts those of us who take care of this population and try hard to serve them in their homes, in the nursing homes, in their daughters' homes, in all the different places people live, in what I perceive to be an impossible situation. I'm attracted to the possibility that the Office of Civil Rights, as it builds this conscientious objection squad, that we should swamp them with conscientious objection to participating in a system that would discharge a patient to a truck, that would discharge a patient to a situation in which they cannot get access to food, to medications, to personal care. Let's swamp them. Let's just say, okay, I have a conscientious objection to going along with a society that is treating so many of its members with such disdain. And finally, I would point out that one of the things that's most missing in everything that I've been studying in the last few years is comprehensive care plans. The doctors think a care plan is a medication list. The social workers think a care plan is filing a lot of papers to get people eligible for stuff. The care plan is really the heart of serious comprehensive care for people who are living with very difficult situations. And we don't even require it. Do you know that meaningful use in hospitals does not yet require that the caregiver be identified, or that there be a slot in the electronic record to say who's providing care? It's not there. Much less a care plan. There's no slot for a care plan. There's a slot for medications and so forth, but not a real care plan. You know, we have changed from a period in which people died of pneumonia and heart attacks in 1960 to a period in which most of us will die by inches over a long period of time. And we have not changed our care system to match. We have not changed our power relationships. We have not changed what it is we expect in old age. We almost have no movies or news stories about this way of coming to the end of life. We have no reference points. So let's get busy and try to straighten this out before we have to face it with ourselves, with our neighbors, with our family members. And then physician aid in dying would be, or aid in death, would be a really intriguing question of autonomy and the public well-being. And we have all sorts of wonderful debates like this. We can't have a wonderful debate like this on the slippery grounds of the swamp of how we're taking care of one another at the present time in this country.